Hello. So I know that I didn't give a heads up as to me making this video today, but I thought that, hey, I just got off work right now and I have been getting this question of what does a typical day on your unit or on my unit, the step down unit, look like. So I thought it wise to just come and throw it out there to explain to you guys what, for example, a typical shift is going to look like on the step down unit. So I'm trying to see like what day to pick so that I can explain to you what that shift looked like. um okay, I think I have one in mind. I'm just going to give it a while so that maybe those who did, I know I didn't tell anyone that I'll be coming on live, but let's see those who can come in and what we can talk about for this live session. If you have any questions, drop them in the comment section. I'm very open to answering questions, whatever you want to know about the step down unit. I feel like the internet doesn't, or maybe like YouTube, so many nurses out there don't talk about the step down unit. So there's so many questions that people are like, hey, step down unit, what is the step down unit? What is the PCU unit? What is the IMCU unit? What is the IMU unit? What is the intermediate care unit? What is the transitioning unit, as some people call it? So I have been getting a lot of questions as to like what is the patient ratio, what is like the patient acuity on this unit. But for today, I feel like the most numerous questions that I've had is, what does a typical day shift looks like? So before I get started, before I spill the tea, I want to give it a while so that if anyone who kind of catches me online wants to jump in, they can quickly jump in. So I just got off work. As you can see, I'm still in my scrubs. I still have my scrub cap. I still have my scrubs on again, and I still have my badge. Unfortunately, I go to work, I don't do makeup, so the most I can do is just my eyebrows and just a regular Camex. That's about it when I'm going to work. So I don't come and I cake up when I'm going to work. Granted, some of my fellow nurses, when they come to work, they do all the makeup, the lipstick, foundation and all of that, but I don't feel like that is necessary. I don't have that kind of time and energy to do that. Besides, I tell myself, like, for who exactly? So typically this is how I will always go to work. I have my backpack here and my lunch box. I feel very dehydrated. Let me drink some water. I like taking a cup of water with me just to keep myself hydrated, but most especially because I work night shift, I like to drink water because I keep the water cold, so I always put ice in it. It keeps me up, keeps me from not falling asleep. It also wakes up my brain. So yeah guys, hop in, let us chit chat, let us talk a little bit. I am honestly not expecting up to 10 people to be on this live. Again, I just got back from work, and my hands are very ashy, so I just want to apply some lotion to my hands because my hands are very ashy and I have a very dry skin, and so I hate when I use the hand sanitizer and my hands look ashy and white. We're just chit-chatting before I get into a typical shift on my floor. Maybe I'm going to do like a series of, hey guys, last night's shift looked like this, last night's shift looked like this, so that maybe you can compare. Oh, yesterday she said her shift looked like this, but the previous day she said her shift was like so, and maybe 2 days ago she said her shift was like so, so that you yourself can compare, to say, hey, maybe on Wednesday she said it was like this, it looked like it wasn't a tedious shift for her, but on this day it seemed like it was a lot. Mind you that this channel is more of me enlightening people about the step down unit. This channel is more about me letting people know that there is a unit called the step down unit, because I feel like, and I always say this, I feel like so many people don't know about the step down unit, but everybody knows the med search unit, the ED, maybe the mommy baby unit, the ICU. Most people know that unit, maybe the PACU, the OR, but most people do not even know when you say step down or intermediate care, they're like, what unit is that again? So I'm here to shed some light as to what this unit is, and to answer your questions and any burning thing that you really want to know about the step down unit. I'm here. I'm not promising that I'm going to do this every day, or I'm not sure how often I'm going to do this, but let's see how how the weeks and the days and months unfold. Maybe I might just do this when I get off work and I'll be like, hey, last night was like this is how my shift went, but again, we will see. So it is, well, we've had a while on here. I think that I should just go ahead and start talking about what my shift last night looked like. So a typical step down unit for most hospitals, you're going to have 4 patients for 1 nurse. But again, I know that because of the nurse shortage, some units or some hospitals are going to be having like 5 patients for 1 nurse or 6 patients for 1 nurse. So if I say that my hospital or my current hospital has 4 patients for 1 nurse, do not hold it against another hospital that might have like 5 patients for 1 nurse, because tell you what, my previous hospital had 5 patients for 1 nurse, but my current hospital has 4 patients for 1 nurse. Now, I love coming to work kind of like 15, 20, 30 minutes early, just because I like to have an idea about the sort of patients that I have been assigned for that shift, so that when I'm getting reports, if something that the nurse tells me during the report kind of sounds incomplete to me, I already have a heads up as to what this patient is and to know what sort of question to ask. Take for example, let's say a patient comes, let's say I came in early, right, and I know that one of my patients kind of like is on diuretics, and the patient has been peeing a lot. When the nurse is giving me report and they're like, hey, the patient has a Foley for I and O, and the patient is on Lasix, because I already know that, it now helps me now to be able to ask the nurse that, hey, what's the patient's potassium? Hey, what's the patient's blood pressure like? But when you come on and then, just at the time when you have to get shift report and the nurse is giving you all those information, it's like you're just taking in all the information and not necessarily process the information and be ready to ask more questions. Granted, some of the things you might be able to go back and find them in the notes for the patient, but sometimes I just like to start my shifts being knowledgeable, so to speak. So when I come in, I keep my bag and everything that needs to be kept in the break room, and then the next thing I do is I come to the computer, I check who the patients that have been assigned to me. I go and I open the notes. I see, okay, patient A has is let's say John Doe. John Doe came in for shortness of breath. Okay, then I want to know what's the patient's oxygen level, O2 sat, how much oxygen is the patient on. Maybe is the shortness of breath related to pneumonia? Is it related to COVID? If that is the case, are they on any antibiotics? Are they on any steroids? Are they on remdesivir for the case of COVID? So I just kind of get those kind of like ideas. Is the patient scheduled for any procedure maybe the next day that I have to be looking out for? Maybe an NPO status from midnight. Has consent been signed already for that procedure? So that is for me an advantage of coming in early to work. So last night I came in, and again I had 4 patients. Most of the patients had respiratory issues. One was COVID, one was kind of like shortness of breath, the other one had like a wound drain abscess. The patient came in for an IND, and the other one came in for like stroke-like symptoms. So given that I already know the acuity of my patients, I already know the oxygen levels, I after finishing the report, I come down to the nursing station now, and I open up the notes. Especially, you want to know like what the doctor has said with regards to the patient, especially the plan of care for that patient. Let's say one of my patients, okay, previous night I had them, they were on like very high amount of oxygen, they were on high flow, and then today I come in and they are like on like 2 liters. So I wanted to know like, okay, what is the plan of care? Are they planning to discharge them home on 2 liters? Are they planning to send them to like a health facility, or is the patient still here maybe for like some other procedure again? You know, just go through the notes. So when I go through the notes, I like to write down some little things that I feel like might be important for that patient during my 12-hour shift. Let's say, for example, one of my patients was on diuretics, and the patient's potassium was kind of on the borderline. So I had to write that down because I knew that the patient was going to be getting their scheduled potassium, but I knew that later on the labs are going to be drawn so that, you know, they can recheck to see like, okay, did the potassium balance out? And if so, to know that the next schedule directing maybe should be held or is safe to be given. So I like to always write down those things so that I can plan ahead, so that I can know what to expect, so to say. So so for last night I came, I wrote down everything, and then typically, this is just me, I like doing my assessment when I am giving the patient medication. Again, I'm not walking into my patient's room without knowing who they are. So that is why I like to always go and read notes from these patients so that I know what to expect maybe during my assessment, know what to expect in terms of during the shift. Let's say, for example, you have a patient who is on like 40 liters of oxygen. You should know that, hey, to watch out maybe for the patient's O2. Let's say if you have a patient who tends to brady, if the patient has like a standby digoxin, you just want to not digoxin, if the patient has standby atropine, you want to know that, hey, to hold the atropine, you know, to just know that, hey, the patient has the atropine just in case you would need it. So I like to always write down my notes so that I am prepared for my shift, if that's the right word to say. So when I write down the notes for all the patients, it takes a while. For me, it can take me like maybe like a good 30-45 minutes, maybe an hour, depending on if these patients are new to me. So one thing about me is that I like to cluster my shifts, because when you cluster your shifts together, they tend to assign you patients that will continue all through that clustered days of shift, if you understand what I mean. Let's say you cluster your shifts and you're working Monday, Tuesday, Wednesday. The patients that you have on Monday, there's a high probability that you're still going to have those same patients if they have not been discharged, if they have not, expired, or if they have not been downgraded to med surg. There's a high probability that you're still going to have the same patients. So for the Monday night, it takes me a longer while, to dig out all information regarding all 4 patients. But let's say on a Tuesday, when I already know everything about the patient, I'm just coming out to see, like, okay, patient was supposed to be going for this procedure. What did they say? Are they planning another procedure? Or what was the outcome? Was everything good? Did they find what they were expecting? If not, is the patient, maybe scheduled to be discharged the next day? You just need updates at that point. But when it's on the first day, you're like digging, it can take like 30, 45 an hour, maybe sometimes. But in a case where I already know I just need updates, sometimes it might take me maybe like 30 minutes, 15, 30 minutes max. So after those notes have been taken care of, I try to get the patient situated in terms of, hey, do you want water? Do you want maybe any pain medicines? And then, you want to know what their vital signs are, if there's any patient whose blood pressure needs immediate attention, if there's any patients whose maybe blood sugars need immediate attention. So I like to get those things out of the way, maybe take out evening trays, maybe empty Foley's, empty, any drains that the patients have, so that their 9 p.m. medications, you'll be getting ready to go pull out their medications and come give to the patients. So I know that we were taught that when you want to administer medication, or when you what's the word, when you want to attend to patients, you have to attend in terms of acuity. In this case, I would like to say that you are attending to patients. Yes, you attend to patients in terms of acuity, but there are certain times that you're going to have patients that you would want to attend to them in terms of maybe their diagnosis. Let me explain what I mean by that. Let's say, okay, like last night I had 1 COVID patient and 3 regular patients. You don't expect me to go and attend to the COVID patient first and then go and attend to the other 3 later on. Common sense would tell you to go and attend to the other 3 before you come and attend to the COVID, given that the COVID patient is stable. So in that case, now what I would do is, attend to the patients who might just need a quick in and out. For one patient, the patient just had 1 pill, and the patient wasn't deserving of the insulin for last night because blood sugar was within normal limits. So that was the patient I first of all went in to check. So when I'm giving my medications, I'm doing my assessment. When last did they poop, any pain, listening to bowel sounds, lung sounds, checking their skin, checking to see if there's any redness or if there's any preventive dressing at their butt, checking the Foley to know if maybe there is the safety divisor holds the Foley in place, checking to make sure that their O2 is sitting fine. If the for one of my patients who had a drain, I had to come in and make sure that the side of the drain was looking fine, wasn't kind of oozing out, it was dry, it was intact, and the drain was draining, do all those basic assessments. So while the patient is taking their medications, you're doing all that assessment, but make sure that you are checking your vital signs, especially if patients have like blood pressure medications, or any medications that can tamper with blood pressure, any medications that can tamper with like their O2, any medications that can tamper with their labs. You want to make sure that you are actively checking those ones first before you are administering medications. So I went in, gave just this 1 pill to the patient. So this patient in question had drains. So I checked the drain side. It was, draining okay. The side was clean. The patient had like a little wound. I just had to wrap up that wound, and that was it for the patient. Just assess the patient. The patient was pretty much there for, not for just for some respiratory issues, so it wasn't really a big deal. So the patient just had that one pill for me. The patient wasn't deserving of the insulin, and then the patient had their breathing treatment, just check the dressing, and then that was it. After that, now I moved to the next patient, repeated the same thing. The next patient came in for an IND. The dressing was okay. That was all for her. No, that was all for them. And then checked the patient's pain level, checked the patient's blood pressure, because when a patient is in pain, it tampers a lot with their blood pressure. So the blood pressure was okay. The patient needed some pain medicines. So good thing I'd already asked if the patient needed pain medicine, so I knew to come in with the pain medicine. So I was actually in there with the patient's scheduled medication as well as the pain medicine. And there was a little leaking underneath the patient, because the external catheter was kind of not well placed by the tech. So I just had to adjust it, then change the patient's bed pad underneath them, and then that was it. Patient could swallow their pills. Patient was very much independent. The patient was just there just for their wound. Went now to the next patient. Patient was also there for respiratory issue. Now this patient was one of those patients that kept me on my feet last night. And so this patient, for respiratory patients, most at times we would want these patients to do what we call respiratory. Some people call it respiratory toileting, some people call it respiratory exercises, whatever you call it. Basically, they're using an incentive spirometer. What an incentive spirometer is, these patients have to, do like a breathing exercise where they breathe in so that it helps in the expansion of the lungs. So this patient came in with respiratory issues, like I said earlier on. So whilst I was assessing the patient, while I was scanning the patient, popping out the medication, the patient was actively doing the incentive spirometer. And then once the patient did the incentive spirometer, the patient kind of like downgraded. The patient started, there was a change in status for this patient. Just for HIPAA sake, I don't want to kind of explain in depth what happened, but just know that the patient's respiration kind of went down south after the incentive spirometer exercise. So I had to call the respiratory therapist. She came and they had to administer a breathing treatment for this patient. Basically, we were in the patient's room for like a good 30 minutes just for that issue, because we had to get the patient stable before stepping out. So one thing with me is that if the monitor is beeping for a patient and I come into the patient, I have nurtured myself never to step out of the room until the patient's telemonitor numbers look stable. Even if a patient's O2 is, kind of starting in like 85, 83, and, even if it takes me like 10 minutes, 5 minutes, I have just nurtured myself to stay in the patient's room until that O2 or oxygen saturations become stabilized. If it is blood pressure, or if it is the heart rate, or anything, if the patient's status kind of changes, there's just something about me that I cannot step out until the patient looks okay. So I had to stay in the room with the respiratory therapist until the patient, came out of that situation. It took a while, like a good 15 to 20 minutes, but yeah, we had to stay there until the patient was finally stabilized in terms of their oxygen requirements. Gave the patients medications, assess the patient, listen to the lung sounds, empty the patient's Foley. Whilst I was there, I had to do everything all at once. Remember to cluster your care for your patients. You don't want to keep going in and out, in and out. Just do everything whilst you're in the patient's room. Once I was done, then I moved now to the next patient, who was kind of like a stroke-like patient, and took care of the patient. The patient also was on oxygen, but the oxygen needs were trending down, meaning that I had to reduce the amount of oxygen that the patient needed. So give the patient, scan the patient. Unfortunately, I had to crush the patient's pills, so I had to go crush the patient's pill, bring some applesauce, gave the patient, and that was it for medication rounds. Now, once medication rounds are done, before stepping out of each room, I make sure that the patients comfortable and ready to go to bed. Remember, I'm working night shift. The patients are comfortable and ready to go to bed. So while they're comfortable, ready to go to bed, everything is set. If they still want to watch TV, I just make sure that they have everything within reach. Bed alarm have been turned on for the patients who might become impulsive and want to get out of bed without permission or without letting me know. So I get everything situated and then I walk out of the room. Now it's time for me, after giving all my medications, it's time for me to come on and then start documenting. I know that for new nurses, it's going to be a challenge for you to remember your assessments for each patient. But again, like I always preach, these things come with time. These things will come with as you age in your profession. I know some nurses who would do their assessments in the room and do their documentation there and there in the room, because for them, they say that they tend to remember when they're in the room and they document everything. For new nurses, I can understand. For old nurses, maybe that is their own way that they have accustomed themselves to go about or practice their own nursing. Everybody does things differently. I'm going to explain how I do mine. Fortunately or unfortunately, I tend to remember my assessments for my patients. Now, maybe I might not remember like numbers. Then sometimes I might go back into the patient's room to go and check the numbers, maybe like blood pressure, or what was the O2 sat like, or I don't know, maybe something in the room that I might have to go back. But when it comes to the assessments, most of the times I always just remember. So I come to the nursing station, I start documenting room A, room B, room C, room D. Documentation again would depend on if that is your first shift in a cluster or if that is your second. If it's your second, you already know it's like boom, 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 boom. If it's your first, you have to start documenting everything. Sometimes you have to remember, and honestly, sometimes, like I explained, you have to go back in and go check your numbers and then come back and document what you saw or what is about that patient. Once documentation is done, then I now start looking at, hey, is there any patient who needs any other attention? Maybe Foley needs to be empty, maybe they need pain medicine. Mind you, this might now be like 11 p.m. You will just make rounds. Another thing about me is that I like to always check up on my patients. Some nurses will come to work and they just sit in their at the nursing station and they document, or when we are just chit-chatting and then time flies by and then that is it. For me, there is just something about me that just knocks me and wakes me up, and it's like, hey, it's time to go check on your patient. So I can tell you that I'm one of those nurses who will check on my patients, like, I will not boast to say every hour, but maybe like every 2 hours or every 3 hours, but it might be less than an hour, because I like to always know what is happening to a patient. Take for example, like I had a patient who was braiding, and when that telemonitor braids, I like to always throw my eyes on the monitor so that I know how low the patient went and for how long. So I like to always know and catch things about my patient. I don't like to be told what happened. I like to always catch things by myself, and I'm pretty good at catching things about my patient by myself, because again, like I said, I'm always rounding on my patient. That's just something about me that I guess it's just going to be my ride and die. Like, I'm always rounding on my patient, and I can tell you that it's a good practice, because I cannot even emphasize on how many times I have caught a situation about a patient that was due to my rounding or my frequent rounding. I remember there was a time when I was just rounding and I was like, you know what, let me just round, let me just go around the unit. And then, mind you, I met a patient who was supposed to um, stay in bed, who was out of bed. And guess what? It was something else. I don't want to go into details with that. So when I round, I'm asking, like, okay, who needs maybe sleeping pills, or maybe who needs something. You just want to round and check on the patients. And then sometimes some patients now might start throwing some fits in terms of maybe heart rate or maybe chest pain, and then you have to go do an EKG, and then you have to do a bladder scan. So after my medications, then I discovered that one of my patients had not had number one, had not peed for like all day yesterday, and so I had to bladder scan them. So when I bladder scanned them, at that time the bladder wasn't retaining as much as I thought. But this patient was having so much fluid. The patient was on normal saline, on continuous fluid. So it felt like, okay, this patient is getting a lot of fluid. Where is the fluid going to? Like I always preach, the step down unit is going to be that unit where you're going to be thinking a lot. Like, you have to brainstorm, you would have to reach out to the provider, you would have to make suggestions to the provider. So I had to reach out to the doctor and be like, hey, this patient has not peed in more than 24 hours. The patient is on continuous fluid, but I bladder scanned the patient, and the patient is only having less than 500. What do you want us to do? And those are some kind of things that you should be proactive to do for your patients. Now, when I did the bladder scan, it was now time for me to do my midnight documentation. So another thing why my unit has just 4 patients for a nurse is because of the number of documentations, especially when it comes to the assessments. You have to document Q4, you have to document every 4 hours. So you document maybe at 8 o'clock, midnight, 4 a.m. So after I had done bladder scan for this patient, it was time for me to go to my midnight documentation. Once I was done, checked again on my patients, it was time for me to go get my lunch break. Went for my 30-minute lunch break. Before I come back and sit in the nursing station, I always check again on my patients, just to know, hey, in the past 30 minutes, did anything happen? Before I come sit down and see, okay, maybe labs have already been generated. Look up the lab numbers, potassium, and all those beautiful numbers. And if there's anything that needs the doctor's attention, you call the doctor, and you give them a heads up. And then maybe around that 4 o'clock, some patients are already waking up, some patients are already asking for their coffee, some of them are asking for pain medicine, some of them want to go number 1, number 2, maybe some are nauseous, some, believe it or not, maybe are breathing at that time, because when patients are sleeping at night, that's when we get most of our sinus breathing episodes. Or maybe patients are like they want something for nausea, maybe a headache, or something just comes up. So then it's going to be time for me to document my 4 o'clocks. When I document the 4 o'clocks, and then pretty much you're now updating your report sheet, what you're going to tell the next nurse. Let's say for the patient who had like a bout of respiratory issues, you're going to write it down, how many liters of oxygen that you've bumped up the patient to, how long that lasted, because this is going to be very vital information for the nurse to pass on to the doctors, so that they can act accordingly in terms of the care for this patient. After you've updated that, you check again on your patient to make sure that they are clean. You check on maybe they need, maybe their IV fluid bags are empty, you want to replace that. Aside that, then it's going to be time for you to get ready for the nurses to come and give report to the next shift. And it's always ideal to give bedside shift report, because, well, let's save that story for another day. I'm going to tell you guys why it's very important to do bedside shift report, because something actually happened to me, something very interesting that you might want to know. But yeah, that's a typical night shift for me as at last night. So I had a bout of respiratory issue with one of my patients. The other one was in kind of like severe pain, and blood pressure issues. The other one was kind of chilling, and then the other one too had like I had to keep monitoring the patient's oxygen levels, back and forth. So aside that was what my night shift last night looked like. Would I say it was tedious? I do not want to say it was tedious, maybe because I have gotten used to the pace and the tempo of how the unit works, and so for me it's kind of like normal. But for a new nurse, I would kind of see the nurse seeing it as stressful and tedious, especially with the patients who started having that bout of respiratory issues. I can see that new nurse freaking out. I can see that new nurse feeling like stupid, just because they might not be able to be proactive in terms of like, okay, what do I do, who do I call, who do I reach out to, what should I be expecting, what should I be doing while I have let the doctor know, what should I be doing now for the patient while waiting for response from the doctor. So I can see a new nurse being frustrated or being flustered or being overwhelmed with that. But for me it kind of seemed like a something normal. um would I say I would want the same patient load? At this point, I already know what my patients are. Like I said, I always like to get back my patients, because it's always easier to just continue with the patients that you already know than to come and start again with a new patient all from the start. I mean, don't get me wrong, you might get a patient that is going to be easier, but again, I always like the continuity of care for the patient. So I always like keeping my patients, even if I'm working like 3 days in a row, 4 days in a row. I always like to have all my patients, um all I always like to have my patients work with me all through that 3 or 4 days. Would I say that it was an amazing shift? I would say that it was an amazing shift, because believe it or not, I have had worse days. If I had to rate this shift in terms of what's my impression about the shift, I would give it a 4 on 10 in terms of how worse was it. Given that a 0 meant it was a chilled shift, and a 10 means that it was like an exhausting, it was a tiring, it was a running around shift. So for last night, I would give it like a 4 on 10. Mind you, I have had nights, or I have had shifts that were probably like 15 on 10. I kid you not. But last night I feel like it was a chill shift. Pretty much I knew what to do. I had moments when I was chill. I had moments when I was relaxed. We chit chatted with our fellow nurses. There were moments when I went on my break. I went on my second and third breaks. you know I had moments when I could quickly check my emails, quickly check text messages, and yeah, I would say it was a pretty chilled shift. Um, So that was it for my shift last night. I kind of feel exhausted because hey, I cannot cheat nature. It's time for me to go to sleep. But if there is anything that you would want to know about working on the step down unit, what the unit looks like, what a typical shift looks like, I just explained to you what my typical night shift would look like. If you needed any explanations, like I said, I will try to make these more often so that I can explain to you what my different shifts look like. And on that note, I'm going to end this live here. I didn't think it was going to be this long. I think it was this long just because I had to explain certain things. In the next live videos, it's just going to be me going straight to the point. Maybe after I've gotten reports and I'm just telling you, hey, patient A, patient B, patient C, and patient D, this was what happened, this was what I did, and this is how chill the shift was, or this is how tedious the shift was. And maybe I had to call a rapid response, or I had to call a code blue, or code sepsis, or code stroke, or whatever good thing that makes our floor bubbling. I would kind of just explain it to you guys. Now, if there's any other questions you guys have, please drop it in the comment section. I read your comments, believe it or not. And so I'm going to answer them hopefully with a live or maybe like a more structured video. But if you have any other questions for me, just leave them in the comment section and I'll respond to you in my next live session. Take care, guys, and I hope you guys have an amazing weekend. Bye, guys.